Welcome to Demystifying Mental Health, where we bridge science, soul, and storytelling to heal minds and communities. I'm Dr. Alauna, America's trauma psychiatrist, and today's topic hits deep: mistrust in medicine and mental health care. For generations, our people have carried a protective skepticism of institutions that didn't always protect us. And according to a 2024 Pew study, 51% of Black Americans believe the US healthcare industry was designed to hold Black people back. That's not just data, that's our lived experience. But today, our goal is to move from paranoia to power and to turn justifiable fears into informed action. To help us unpack this, today I'm joined by Dr. Roger Mitchell, President of the National Medical Association, a voice of truth and justice in medicine. Please welcome Dr. Mitchell.
Thank you for letting me be here. It's a very important topic. Thanks for letting me be here.
Absolutely. Today's episode is From Paranoia to Power, using facts to heal minds and communities. And here on blackdoctor.org is a place where people come to get information, to understand their own health, to understand what's going on in the world. And I don't know about you, but personally, I find it hard sometimes to know who to trust and who to believe about facts and data. So you guys want to really, really hear this conversation today. Let me tell you a little bit more about Dr. Mitchell. Dr. Mitchell is the current president of the National Medical Association, which is the nation's oldest and largest organization representing Black physicians. He's a board certified forensic pathologist and previously served as president of Howard University Hospital and chief medical examiner for Washington, D.C. And he's been chair of pathology at Howard University of College of Medicine. He is now serving as a national voice of health equity and justice. And he co-authored a book called Death in Custody: How America Ignores the Truth and What We Can Do About It, as well as he co-hosts the NAACP Image Award nominated Official Ignorance podcast. And Dr. Roger just has so much wealth of information to tell us about what's going on in healthcare. And unfortunately, right now, places that we used to be able to get information, like the CDC and other health entities, the WHO, we're disconnected from information about our health. So what Dr. Mitchell, you are doing such a service for our community. So just tell us a little bit more about yourself. What's not in the bio that we need to know about who you are?
Well, the first thing is that I'm a father, I'm a husband. I've been married now for 23 years and have three wonderful children, all at Howard University Hospital, all at Howard University. And, I think that's important. When we talk about mental health, when we talk about all these accolades, understanding what grounds a person, understanding kind of where I come to get watered, right? Because if you're doing this work, you're pouring out a lot. So where do I come to get watered? Where do I come to fill the cup? Is with my family and in my community. I'm also an ordained minister. So if I get to be a little bit preachy, you just kind of put a finger up and I'll know that I'm getting a little bit preachy. And so that's really what people probably don't know about me. But I've spent a lot of time in this space surrounding violence as a public health issue. We talked about death in custody, but now traveling the country, galvanizing Black physicians, our patients, and our community surrounding equal access to care. That's important to me. As things are being turned back, we need to make sure that we're doing our job to make sure that care is front and center, and that even though the government may be making decisions on who has access to the insurance to pay for care, we as physicians, particularly those that center the marginalized, center the disenfranchised and the disinherited, we own the care we give. And so we can set the price we have for the care that we give. And sometimes that price may be free. And so we have to understand that we have a responsibilities as caregivers to respond in this moment, to provide care for those that may not have it, to ensure that people don't die from it. I'm a forensic pathologist, and I often say that I see failed policy on my autopsy table.
Whew, that's deep. Failed policy on my autopsy table. And we're absolutely, living through a war on public health. And I'm just curious about your thoughts on like how we got here. How did we get to the point where we have the government, which is supposed to be structure for the people, seems to be undermining data and information about what's happening with the people. So, what thoughts do you have on the things that we're seeing these days?
Well, there is a long legacy in this country, regarding the health of people, particularly Black folk. There is a historical arc that has minimized and alienated the health and wealth of Black and brown people in this country. So it's not new that there is this lies being perpetrated on what leads to better health outcomes. So that's not new. What's new is that I think more of us realize how important science and medicine is to our community, and the
Mhm.
importance of us holding on to the truths that go along with science and medicine. So we're not that far off from COVID. COVID was probably the best example of how marginalized individuals that aren't don't have access to regular care and are suffering from chronic diseases like high blood pressure, like obesity, like diabetes, the inflammatory diseases, the auto-inflammatory diseases, mental health, the chronicity of smoldering depression and anxiety, communities that were chronically inundated but not receiving care. When COVID came, COVID exposed the inflammation that was happening in not only our bodies, but in our community. And so that exposed us. And we then knew how important getting as many people access to care, pausing any restrictions on individuals that needed care, how important that was to saving lives.
Mhm.
Because we knew that, now we realize when it's being attempted to be rolled back, that rollback is even more prominent. And so I'm always looking for the silver lining. The silver lining is that there's more people awake to what is happening than probably there has been before. And if we use that notion, that visibility that we have, then we can bring community together, not just physicians like you and I, but everyday community, everyday patients are realizing how important their healthcare is.
I'm glad you said that because I think that really touches on an important factor of what we try to do here on Demystifying Mental Health is just educating people about topics that maybe, only just now seem to become important, but it takes sometimes traumatic experiences like COVID and other, things that there's no denying that the world experienced that together to be able to recognize those commonalities that it breaks in the system. So let's hone in on that because you talked about historical trauma. We know that there have been there's story after story that we could pull out about how the medical system has been biased against Black people or used our bodies to make advancements for that benefit everyone else more than what benefits us. And I think that just me personally, as I look at the attack on science and data, I think part of that because the science and data is super clear that shows that it's not a moral failing of the Black community, why we have higher levels of obesity or diabetes or even substance addiction, or why we may have more struggles with mental health issues or things that even land people in the criminal justice system. Because all of these, when we look at the data, it consistently shows that beyond anything that a person does, the environment around them that they're placed in, the invisible psychological insults and damage of microaggressions and macroaggressions and facing discrimination and racism, as many of as we did as we went through the halls of medicine to become doctors, while people looked at our skin and questioned whether or not we actually had the intellect or the capability to do those things based on such a superficial judgment. So for me, it feels like this culmination of we have to break the science because the science is now showing and demonstrating the reality that the fix needs to come from investment of dollars in these communities, and that's not the answer that many people want. They want to be able to blame the people who are struggling because of the result of hundreds of years of disinvestment and active sabotage of our health and our wealth. But we don't, here on blackdoctor.org, the good thing is that we have the resources to rebuild trust. And I think that's really important. That's why I wanted to highlight the National Medical Association and what we do, because when you have community, you're able to put together facts and representation and bring compassion back to medicine and public health and data. So before we go further, can you just tell them a little bit more about the NMA, what they do, and how the NMA is serving the community?
Yes, I mean, the National Medical Association, like you said, was started in 1895. I mean, the whole purpose of the National Medical Association was to ensure that our community had access to care, and our physicians have access to places to actually treat our patients. Our
Mm.
hospitals in this country were not allowing for the admission of our patients. We had no admitting power. And this was before there was a medical staff office that required credentials and checked credentials. Really, it was the association, the American Medical Association, that would check your credentials and certify the fact that you were able to practice medicine in a way that is competent. Well, they weren't, the
Mhm.
AMA was not admitting Black physicians into their organization. And so the National Medical Association was created for that purpose, so that we could show competency in our provision of care. And so we do the same thing now in when nobody was thinking about national insurance, when the civil rights of America was at risk in 1965, when our voting rights were at risk, when it was separate but equal and we were drinking from other water fountains. Our hospitals were segregated. We were all in one unit, in one ward, no matter if you had appendicitis or you were suffering from a foot ulcer from diabetes. We were all in one unit. We were segregated. And we didn't have access to the ability to pay for our care. Well, then Montague Cobb, who was the president of the National Medical Association, he also had the opportunity to be the president of the NAACP. He was at the table fighting for national health care that ended up being Medicare and Medicaid. Other
Mm.
organizations weren't. It was the National Medical Association that was involved in that fight. So now, 60 years fast forward, 2025, Medicaid and is attempting to be removed from people, that to ensure that we're trying to save dollars. Well, the reality of it is that we are at the forefront of advocating against that, right? Advocating for our patients, advocating for our physicians, advocating for our communities. And it's not just Black communities, it's really all communities that need access. We know more of our white counterparts are accessing Medicaid in a way that is reliable for their families. This is the single mother that has a disabled child that is working two jobs and needs to not only get care for herself, but for her children. Disabled children are on Medicaid. SNAP benefits, food benefits are all part of Medicaid. A lot of people don't understand how expansive Medicaid is. It's something like 1 out of every 5 children are on Medicaid. And so when we talk about saving healthcare and ensuring that healthcare is moving forward, we need to understand that that safety net is extremely important. I'll be the first to admit that healthcare is extremely expensive and needs reform. But it doesn't need reform by just decreasing the amount of people that are accessing it. What we believe at the National Medical Association is that value-based care is the approach. Getting people into primary care, increasing the amount of people that are performing primary care, incentivizing the workforce to go into primary care. Both you and I are specialists. We enjoy being a specialist, but we need individuals that are going to see individuals when they're complaining just of the tingling toe, which is the first sign of neuropathy due to diabetes, before there becomes a sore on the bottom of the foot that leads to an amputation, that leads to a preventable hospitalization. The National Medical Association is on the forefront of this. I mean, we're talking about getting more of us involved in clinical trials. Right now, there are so many new medications that are focusing on the genome, not the Black genome, but the geographic genome. Individuals that were more apt to get schistosomiasis, which is a parasite that you get in West Africa, those individuals that evolved to guard against schistosomiasis have a particular gene that increases the likelihood of cardiovascular disease and kidney disease specifically. Well, if we know that, then we can develop medications that specifically deal with the chronic renal insufficiencies that go along with that geographic that happens to be Africa. But that gene exists in more than just Africans because of the melting pot that the world is. That's just examples of what the National Medical Association, from our advocacy to our clinical research that we're involved in.
Awesome. That is, and I think that's so important for us to know that there is a African American centered organization that is doing that work, because once again, we're a community that has been tested on, that has been lied to many times. And so many people cite the Tuskegee experiment and cite, the experimentation that was done on women to develop anesthesia and OB-GYN practices and things like that. But we have come a long way in the ethics of how we do clinical research, but it also level or layer of comfort for people to know that this organization is really working hard to make sure that we are represented. Because as you mentioned, if we are not part of the studies, then they can't accurately account for how these medications work in our bodies and in our communities, and we get left behind. And that's what I find many times is happening, that mistrust of the system. A person may have one bad experience with a provider. Maybe they're like, oh, I want to get a Black doctor, and then doggone it, they have an experience with that doctor. And then what trauma often does is make people generalize, right? I don't want to have that same experience again. So now I'm throwing everything in that bucket. So now I don't want to deal with any person that reminds me of that experience that I may have had. So that's why we're talking about today how when we come together and we really think about what is needed in our community, it has to happen in layers. It has to happen in layers of education to the community, advocacy to the powers that be, but also researching and having data and statistics. I found that one of the most important things about becoming a doctor was that they taught us how to use science to interpret information. And what I hear these days is that people without real credentials, or even sometimes they may have credentials, but they may read a small study, maybe 100 or 200 people in a study, or, anecdotal article, and then they treat that as fact. And they make, all kinds of conclusions based on data that is not as important. I know that the NMA has a journal. Can you talk a little bit about that process of peer review and why it's important to have someone that you can trust to interpret the data?
Well, you said it right. I mean, there's a lot of mistrust, and the Journal of the National Medical Association was developed for the purpose of ensuring that Black researchers that may not have their article even considered in the mainstream journals could be considered. The National Medical Association has a national convention that brings together 26 scientific sections. We have all the scientific sections that allow for us to have these very high-level scientific and medical discussions for our community, centered for our community, in our community. As much as we're a scientific organization, we're a social organization, because you can imagine that there's not a lot of Black physicians in the country where we can let our hair down and be ourselves in our medical community. So it's a safe space. That journal allows for a rigorous approach to our science that's specific to our concerns in our community. And that's what we look for. We look for groundbreaking research, no matter where it is, but particularly that has a lens towards decreasing disease or injury in the African American community. You talked about the Tuskegee initiative that led to the death of many Black men and Black women in our community. But what people don't talk about a lot is this book called Race, Traits, and Tendencies of the American Negro and the Appreciation and Interest. It was written in 1896 by Frederick Hoffman. And in that book, it was an actuarial approach that suggested, because African Americans, Negroes is what we were called in 1896, are of a lesser species, a lesser race, that if the American community withholds care from that group of people, they will eventually die off. And it was really the blueprint for eugenics of the African American community. So, and I'm not making this stuff up. This is not conspiracy theory. This is the history. Actually, he worked for Prudential Insurance. He was an actuarial. And for years, there has been this notion of, why are we spending so much money on the care of Black folk? And that is really the through thread that here in 130 years later, soon to be 130 years later, we are still having the same types of conversations. And one of the big ways that we can fight this rollback on science medicine and its effect on Black and brown and poor people in this country is by making sure that we have the proper pathway of individuals becoming physicians, right? There has the LCME, the Liaison Committee on Medical Education, has now removed the requirement for diversity in retention and recruitment in all medical schools. So it was a requirement that really did a good job at making sure that women, particularly white women, had access to becoming physicians really did a good job at that, and also made it so that Black and brown and Latino and all of the individuals had access. If you were smart enough, you could go to medical school, right? And it was because there wasn't a lot of us that were seeking med school. We needed to make sure that there was diversity laws and policies to say, hey, there are a small subset of Black and brown people that are qualified, that are well versed, and can be phenomenal physicians. Please take a look at them, because if you just go by raw numbers of qualified individuals, there's going to be more white men that are going to come to you as qualified applicants, just out of sheer numbers and access that has been given historically. So please give a look at the rest of the population so that we have a diverse working class, because we know that Black men and women, brown men and women, are more likely to go back to brown communities, Black communities, and provide care. And the literature says that that care is better received, and that care is, there are better outcomes, right? We know that through the literature. So please, medical schools, you're required to make sure that you're meeting this obligation of creating diversity, because not only diversity is good morally and ethically, but diversity is good from a standpoint of health outcomes. And not only is it good for health outcomes, it's good for the bottom line. If you're if the money is important to you,
right,
it's good for the bottom line, dollars and cents. Well, now that requirement doesn't exist anymore, not only in medical schools, but also graduate medical education. Graduate medical education also doesn't require it. And on top of that, if you're an individual out of this HR1 law, if you're an individual that needs loans, smart enough, got in, were selected, but you don't have enough money to actually pay for your graduate medical education. So you have to take loans out, not get a handout, but take loans out that you have to pay back. Now those loans aren't available. You can't take out more than $200,000 in graduate loans. So if you're not coming from a family or a community that can help you pay for beyond $200,000 in loans, which now is the common stay for medical school, particularly those of us that are the best and the brightest, man, we want to go get an MBA and an MPH and go to medical school, or a law degree and go to medical school, so we can be best suited to serve our community. We can't get all of those degrees because we can't get the loans, not because we're not smart enough, not because we can't pass the test, but because we're not coming from a family that can afford it. And let me tell you something. This is not just going to affect Black folk. This is going to affect a whole bunch of folk that can't afford. So only the elite of the elite can be physicians.
So that, for me, it seems like we need to activate as a population. I know in my role as president of Mary Susan Moore Medical Society, which is a nonprofit organization for Black women physicians in the medical pipeline here in Houston area. That's a big part of our push, is raising scholarship funds and really mentoring, reaching for those people in the pre-medical state, before they get into medical school, mentoring them through medical school and residency, and making sure that throughout all levels of their career that they have support and representation. Because as you mentioned, now those of us that are in the door, we have to work to keep that door open. Because the system is, they're systematically disinvesting from us in order to create bottlenecks and barriers and other things. So that means those of us in this space have to really step in, advocate, and hold that door. Or we turn into hold door. What was that? It had to get it. I don't know if you know.
Listen. I was just in New Orleans and speaking to a group, and it was a majority group of white healthcare administrators. And they asked me, they said, if you could wave a wand, what would be the biggest change you would make in the American healthcare system.
Mm.
And I said xenophobia and racism was the biggest, one of the biggest things. But
That
then I
right there.
turned to them and I asked them, I said, how many of you have poor people in your family? More than half the room, hands went up. I said, how many of you have people in your family that have been incarcerated or are incarcerated now? I said, don't be upset. Raise your
Yeah.
hand.
Get that hand
More than
up.
half the room
Yeah.
raised their hand. And I said, these are the sameness. These are the sameness that the policies that are happening in this country fail to recognize. So when we say this is an attack on us, I just want to elevate. I'm a black man. We're on BDO right now. We're talking. I'm National Medical Association. I went to Howard. You know, black on black on black on black. But one of the things, you talked about my book earlier, Death in Custody, how America ignores the truth and what we can do about it. My co-author, Jay Aronson, follow me. I'm going somewhere with this. My co-author, Jay Aronson, is a white Jewish man. And when we are out on our book tour, I often bring up the poor white family. And he said, I never bring up the poor. This is he talking about himself. He says, I never bring up the poor white family, but the black man is always bringing up the poor white family.
Yeah.
Well, I'm a student of Fred Hampton. And what Fred Hampton was doing in Chicago when he was bringing people together, he was bringing poor black people, poor Asian people, poor Hispanic people, poor white people, all together, understanding that our commonalities outweigh our differences, and the effects that today that is happening surrounding healthcare is affecting all of us. So the us vote is huge. And I want your listeners to understand when they use the language of us, yes, black folk are in the us. I'm us. But there are other us's that if we're going to build a coalition that really frees America from the tyranny that we're seeing today, that us vote has to include all of us that are being affected by these policies. And let me tell you, it's not just black folk, although black folk, let me tell you, we are getting hit the hardest, and we will die the first. But boy, we need everybody in this fight for health equity.
Sure. We tend to be the front line in every battle. It really, to tell the truth about it, and the realization of how much, when I think about where we are as a country, everyone has contributed, but Black folks have truly been the moral compass of this country. And when progress is made for us, it makes progress for every other type of person in this country. And it really is interesting to me, this concept of why people are so resistant to the idea of diversity, because we live on an earth that is very diverse. Only certain pockets have, more of some type of people than another, but the diversity is the norm. It is the reality. So anyone who is fighting against the idea of having to learn about and be around other cultures, other people, other belief systems, that comes from a space of fear and ignorance that drives this tribalism. All our isms, you don't get me on this amygdala, because I love talking about the brain and how fear is driving what we see when we're talking about hate and hate speech, and people who are embracing Nazi concepts and fascism and those type of things. We're talking about people who are operating in fear and ignorance, and that allows them to imagine that when I see this other person, these traits or characteristics mean that I have supremacy over them. Well, I got news for you, okay? Because I think we do ourselves a huge disservice by not talking about the science of that we are one human race, and that genetically we are 99.9% the same. The little bitty teeny tiny parts of us that make our differences, whether it's the shape of our nose and our ears, how tall or short or our longer hair our hair is, or our skin tone and color. These are teeny, tiny portions of our genetic makeup that cause us to have skin tones that are different, and hair texture and color that's different. And we have made so much out of those things because we think genetics and this information has only been available for maybe the last 20 years. I came out into medical school right in the time when the Human Genome Project was being announced and some of the results were coming out. So this was emphasized in my training, that we're one human race, and what we really are is a lot of different ethnicities, genetic changes that happen because of UV exposure and the nature and environment where we've developed over a long period of time. But this concept of race in the black and white terminology that we use it in really is not grounded in any kind of science. And so for us to still, it's important. Yes, there is black as in the black community for sure. But it's also important to understand that our eyes and our superficial characteristics do not don't represent anything about a person, right? Any category that you put someone in, okay, it's a man, but he's not like all, the other 4 billion men on the earth, right? Everyone has these individualities, yet our xenophobism, our all of our isms really blind us from seeing the uniqueness, the humanity of each and every individual. So I'll get off my soapbox on that one, but I do think that you made a really, really important point in talking about how critical it is that we understand that this is not about this. We can't just make the argument about race, because unfortunately, people empathize with what's connected to them, right? If I didn't experience it, I might know that it sucks. Okay, cancer stinks. But then you have somebody in your life who experiences cancer, or you experience it yourself. You're ready to go run marathons, raise money, do all the things, because now that thing really matters to you. So your point about healthcare is that you may not be in danger of losing your healthcare coverage, but I guarantee you that you know someone who is, and you know someone who is on the verge of having a health problem that may not even know about yet, but would be unable to access basic help without putting themselves in incredible financial strain, and many people who would not be able to do it at all. So this is something that makes a difference to all of us. I do have another question for you though, Doc. We talked about how stressful this is and how we've been under siege what feels like hundreds of years, which it really is, right? How does constant vigilance and mistrust affect us mentally? Like, what's the cost of carrying all that stress physiologically, psychologically, neurologically? What is the cost of us being in survival mode for so long?
Well, I got the trauma psychiatrist asking me her question. I feel like this is a test. I feel like
Yeah, go ahead. I'll let you
this
know
is
if you get
a
it right.
test. I need a multiple choice A, B, C. But my career started at the FBI. I was an FBI forensic scientist, and while I was there, I was part of the EAP program, and I supported agents who discharged their weapon or were had to witness someone discharge their weapon. And that employee assistance program, I got trained in critical incident stress management, where I got first exposed to the concept of post-traumatic stress disorder. This is in the late 90s when it was really first coming out. We knew about shell shock. It was just being applied to emergency medical individuals as well as law enforcement. It was before it was being applied to general community and PTSD. So this was early exposure for me in my time at the FBI. During that time, I said, wow, one of the symptoms of being traumatized by violence was a propensity to use violence to solve conflict. So those that were exposed to violence had more of a risk factor of using violence as a coping mechanism to their environment that was coming at them. And so I said, wow, I'm a young guy. I'm in my 20s. I said, man, if violence begets violence, then the hood must have post-traumatic stress disorder. So
That part.
I left the FBI to go to medical school to study violence as a public health issue. And the premise of that, even I went and I said, well, I want to be a forensic pathologist so I can see the end result of violence, whether it was homicides or suicides, and death at the end, because I had a propensity to understand mortality as a indicator for the health outcomes of a community. I thought that you can learn a lot by measuring who's dying from what, and I'm clear on that. And most of our public health system measures death as an indicator for how life is, how life occurs in community or the individual. So I give that background so that you and your listeners understand that I come to this with a clear understanding of how trauma, hypervigilance, always looking over your shoulder, how that can wear on a person. Physiologically, we know that cortisol, bursts of cortisol occur. It's, a hormone that gets us excited, allows us to move when we need to move. If something dangerous is coming at us, fight or flight, right? We know that hormone, just kind of like how you asked me that question. I had a surge of cortisol, right? Because I had to answer a question in front of the expert, right? And so that surge of cortisol, yes, is good. Yes, we need that. Hands start sweating, eyes dilate, you can see more. You're not hungry, right? Because who needs to eat when they are fighting, right? All these things, your muscles get engorged with blood. You're ready to go. Glucose moves out of your liver. It's in your vasculature, right? You're ready to go. Well, imagine that's happening all of the time. You have these chronic bursts of cortisol and no dangers around. Just perceived danger. Just the historical construct of your father leaving and your mother being beaten. Just this worry of whether or not you're going to eat today. Even if there's food available, you worried that you weren't going to eat. Chronic stress. Your mind is always saying, are you sure? Are you sure? Are you sure? Are you sure? Are you sure that that's not going to hurt you? Are you going to sure that that's not going to hurt you? That chronic state of stress wears down on your organs. It wears down on your brain. It wears down on your heart. It wears down on your liver, wears down on your kidneys. It creates small injury to your vessels. It wears down and creates plaque and causes blockage in your coronary arteries. So constant stress can really create an environment. And that's what we know about the adverse childhood experiences. There's a whole ACE study, right, that talks about premature cardiovascular disease in young people that have experienced trauma at a young age, right? Mm-hmm. And so me, my father was crack cocaine addicted my whole childhood. I used to watch my father freebase coke, right? And so because I had those childhood traumas, I have to, and I've learned so much, I have to be very mindful of my cholesterol. I carry high cholesterol. I have to worry about becoming pre-diabetic. I got to make sure that I'm getting in the gym. I got to deal with my stress and my anxiety on a daily basis because of my trauma. And so it's very, very important that our patients take care of themselves, not just our patients, but our providers, right? Mm-hmm. You and I that have to do this work on a regular basis. Our job is to take care of ourselves because that chronicity of cortisol, that chronic stress is really the silent killer that we're all worried about.
Absolutely. We absorb the stories, we absorb the situations, we absorb the pain of the people that we have to work with. And it's interesting to me how in medicine, so much of what we do requires us to meet people in some of their worst situations and circumstances, but they don't teach us that this is traumatic, not just for the individual who's having the health consequence where their body feels like it's betraying them, but also to the physicians and the caregivers and the people who have to see them through those times and the immense amount of pressure that is in our body. And by the way, you answered the question beautifully. So good job, right? I think that's so important what you said about the hood having PTSD. Like the hood legit does have PTSD. And it's not just if you still live in the hood, because those thought processes, those experiences, they carry forward, they pass not only genetically, but also behaviorally. Because if the parent is still, I think about sometimes the consequence of knowing all the things that I know and having seen what I see in medicine, where, I can tell my kids like, oh, well, you do that, this could happen. If you do that, this could happen. And I have to be careful about it because you even knowing that those things happen, you can end up catastrophizing or feeling like those things are always going to occur or that they are more frequent than what they actually are. It's hard to keep that balance when you're constantly being bombarded by other people's painful situations and stories. So thank you so much for really neatly encapsulating how chronic stress and trauma is not just for veterans and military people and police officers. Chronic stress and trauma happens to all of us in some shape, form, or fashion. That's one of the key things that I learned in 20 years of taking care of veterans with PTSD at the VA and other conditions, that all of us have some trauma in our lives. You live long enough, you're going to experience painful things that change the way you think about yourself, other people, and the rest of the world. So, of course, if you're interested in learning more about trauma, I'm Dr. Alauna, trauma psychiatrist. That's what I love to talk about. So you're always welcome to follow me on the social media pages and to join me on detry.org to learn more about the Trauma Recovery Academy and how you can heal from those traumas with a skills over pills approach. Just had to throw that little plug in there. But I want to go back to something that you said earlier, or even before we started talking, that we mentioned there's a lot of problems, but there's also possibility for funding and monies that is coming through even this administration that really could go to targeting our rural communities and our brothers and sisters that don't live in cities, because sometimes we forget that Black folks live in rural areas too, right? And they're not all out there just completely disconnected, but we do need to care and advocate for them. So tell us a little bit about what's in the pipeline.
Yeah, so thank you for that. And, the word rural and the word urban, right? They're dog whistles, right? And if we're not careful, we'll miss it. We'll miss opportunities and think that we're not being talked about. And then sit on the sideline. There are hundreds of rural counties in the South, in the Southwest, in the middle of this country that require that have Black folk in them. There are whole counties that I'm learning, and again, as the NMA president, I'm talking to physicians from all over the country. I'm visiting from all over the country. I'll be in Arkansas in December, and we'll be talking about those rural counties in Arkansas, in Mississippi, in Texas, in Alabama, these rural counties that are majority Black counties. And that is something that is, a lot of people don't know that there are some majority Black rural counties in these states where now there has been a carve out. The big, beautiful bill, or HR 1, has, pulled back millions and millions and millions and millions and millions of dollars for Medicaid, but have put back in $50 billion for states for their rural communities. Half of that money is going to be equally allocated across every state. And then other half of that money is going to be based upon a patient population and need base within the rural communities. We at the National Medical Association want to make sure that our Black patients and our Black physicians, that they get part of that rural dollars, that we're not sitting on the sideline saying, well, when they say rural, they're not talking about us. That is another lie. When they're talking about rural, they're talking about rural. That is us. That is everyone that is in a rural community. We are everywhere. So we want to make sure that those that are disenfranchised and disinherited, no matter where they are, no matter who they are, we want to make sure that they get access to care and that those hospitals don't close and those federal qualified health centers don't close. And, just recently, the Department of Treasury is defunding the Community Development Fund Initiative. That Community Fund Initiative is going towards low rate loans to communities to ensure that individuals can have access to dollars. It goes to credit unions. It goes to these federally qualified health centers where they can get low interest loans to be able to care for people in community. Well, the Department of Treasury, it's been a bipartisan piece. The Department of Treasury has been running this program for years. And during this shutdown, that is, people are being fired from that program, and there are individuals that are that program is being shut down. This is affecting every community in this country, rural, urban. These are the types of things that the National Medical Association and other organizations, although we're a medical organization, we want to make sure that we're at the forefront of understanding this and making sure, because so much is coming at us, that we don't lose what's going on. So we're going to be all over the country really talking about this rural issue. We're planning a webinar in the upcoming weeks to just talk about the $50 billion, how it's going to be allocated, what states are going to be most affected, making sure that National Medical Association members are on any working groups or submitting their thoughts and their proposals, because the states are dealing with it differently, on whether or not they're doing a call for requests for ideas, whether or not they're developing a work group to allocate the dollars. All of those things are different state by state, and our members need to be at the forefront, educating themselves first and then educating community, making sure that those dollars don't just go to community. Let me say that differently, that the dollars go to every community that needs it, not just the communities that someone that thinks that's where it's supposed to go. Every community in this country needs it. It is our money. It's not anybody else's money. It is our money that's being spent. We need to make sure that it gets to where it needs to go.
Absolutely. Show up, claim it, and be part of that process, making sure that our communities are served properly. And if we don't do it, who will?
Man,
The unfortunate,
it's a state of urgency, and I show up that way because I've done thousands and thousands of autopsies, and I've been involved in the death investigation of thousands and thousands more through my career, all over the country, and quite frankly, internationally. And I know that if things aren't done in prevention, then they will find their way to the autopsy table. And that's why I've been successful in moving from forensic medicine to being a chief medical officer of an ambulatory care center and becoming a president of a hospital, because at the end of the day, it's about preventing the morbidity and mortality, the disease, the suffering, and the death of communities that are at highest risk.
Absolutely. We think about even recently with this administration saying that Tylenol is the cause of autism, and so many organizations spoke out and said, no, like that is not, and unfortunately, even with the powerful outcry of all of those organizations in the doctors groups, we still saw people saying, I had a mother today who refused. She'd already had her baby, but she refused to take Tylenol because she was afraid of what it would do to her body. So we are really, data and misinformation is not harmless. It kills people. In pregnancy, there are a lot of potential issues, And one is, there's not many options for pain control in pregnancy or fever control. We know that other medications we know that they can cause fetal malformations and other issues that make Tylenol or acetaminophen one of the most safest options for women to use when they're having complications in pregnancy, and that fevers can create even more complications and problems and risk to the mother and baby untreated than to take something to treat it and be able to bring those fevers down. So that's just one example, a quick example of how every day we're battling misinformation that leads to physical harm and even death. And maternal morbidity in the Black community was already poor before the changes to abortion laws and access to emergency care and deliveries under difficult circumstances. And now we're adding mistrust of common medicines and things that certainly can, if taken improperly, can have physical issues. We know that anything, even the food that we eat, can have side effects in our body. But it's just a really clear example to me of how we need these trusted institutions and these trusted voices to be able to give us context and information when all of this noise comes in that's untrue and that truly scares people. So before we close out today, because we are drawing close to the end of our time, I want to thank our listeners for being here and joining us on blackdoctor.org and Demystifying Mental Health with me, Dr. Alauna, trauma psychiatrist. I want to thank you, Dr. Mitchell, for being here with us and bringing your expertise, but not only that, for your advocacy and your passion about changing the landscape of medicine in this community. So before we go, tell everybody where they can find you, where they can find NMA, and how they can stay informed. Uh-oh, we might be glitching a little bit, but I will just say that nmanet.org is the website where you can find more information about the NMA.
Sorry
And
about
Dr.
that.
That's
Sorry about
okay.
that.
Oh, you're back. Okay.
Absolutely. Thank you for that. NMA.org, www.nma.org. You can find more information about the National Medical Association. But you can find me. You can follow me on all my Instagram, LinkedIn, rmitch_jr. And, and reach out to us. We are doing really, really good work. If you want to be involved, whether you're a physician or whether you're a pre-med student or whether you want to determine, you're an allied health nurse and you want to get involved, we want to be partners. We want to talk through it and move it forward. We're doing a lot in this country and in the community. And quite frankly, I want to come to a state near you. I want to come to your city. I want to talk to your legislators. I want to hear what's important to your community surrounding healthcare. I want to help galvanize your community. I want to bring our doctors with me to be with you. To talk about the issues that are facing your specific community. You're not alone out here doing the work. Those that are listening to you and those that are trying to do the work by themselves or with small groups, we want to partner with you and walk alongside with you throughout this country so that we can galvanize a different outcome because that's the only way that is going to happen. One of the things that I'll say, Dr. Alauna, in my community, you talked about what this administration is doing and how they're acting and the messages that they're putting out. From my community, we say they're playing. They're playing.
Playing in our face.
They're playing. They're playing. And
well, I couldn't say it any better than that. And I want to make sure we close out in time. So I'm just going to actually let that be. We're going to put that pin in it right there, right? We're not going to let them play in our face anymore. Join us and follow us, get this information and be informed about your own health. And join us next month on Demystifying Mental Health. We're here every fourth Thursday from noon to 1 p.m. Central Standard Time. And it's time to evolve.